Okay, welcome everyone. For those who've just joined us, so this is a Northwest Community Pharmacy webinar on Pharmacy First and some wider service delivery support. We've got a number of people who you will have seen on the slides that have rotated through who are going to be speaking. If I can ask all the speakers to introduce themselves as we get going. For those watching this live, just a little bit of housekeeping about the use of Zoom webinars. It's slightly different to the normal Zoom meeting in that you have a question and answer function which should appear at the bottom of your screen. If you ask any questions using that function, our intention is to pick up the answers at the end, and we'll do a hosted session towards the end where we pick up those questions. If there's anything else, if you want to talk directly to the presenters, there is a chat function as well. It's probably best for the question and answer functionality to be used. So if I can hand over to Steve to do the intro part of it, and I hope you enjoyed the webinar and find it useful today.
Good evening, everyone. So for colleagues who don't know me, I'm Steve Riley. I'm one of the regional deputy chief pharmacists with NHS England, and my responsibility is to look after the pharmacy integration, particularly looking in embedding in implementation of community pharmacy services and development of services across our regional footprint. Should we go to the next slide, please, Adam? So just to give you an overview, so the purpose of this webinar is to try and give some support and practical support with the delivery of the Pharmacy First service and wider pharmacy services. So I'm just going to do a brief overview of elements of the Pharmacy First service and some developments. But colleagues are going to look after element review of Pharmacy First service rejections. We then got a couple of community pharmacists and pharmacy contractor colleagues who agreed to come and support and give a view from their perspective about how services are delivered and how it works from their organisations. LPC colleagues are going to do some service delivery tips from the LPC, and then we're just going to finish with a question and answer panel at the end. So as Adam said, if there's any questions you've got as you go through, please feel free, put them in the chat, and then we can pick them up and we can bring people in and join that panel session to try and cover everything off we can. So my section is to give an overview of the Pharmacy First service and some service developments and updates. So initially, what I want to just say to colleagues is, community pharmacy colleagues, is really a big thank you on behalf of the NHS England Regional Team ICB colleagues, and also to LPC colleagues, all the hard work you've done in delivering services overall, but particularly in implementing, and the fantastic work you've done in delivering the Pharmacy First service. We now have through the National Pharmacy Team, a data set and operational report which has been delivered and has now been shared with ICBs. So we're working with ICB colleagues to analyse that data, look how we can best understand how it's being delivered in our areas, where we can target support, and so colleagues will come on to some of these elements shortly. Just to give you an overview at national level, though, we've got a fantastic uptake in delivery of our services related to Pharmacy First and the primary care access recovery work. So over 96% of pharmacies are actively delivering the Pharmacy First service. We've got nearly 91% of pharmacies actively delivering the blood pressure, so hypertension case finding service, and nearly 65% of pharmacies now actively delivering the contraception service. Again, those figures at national level, they do mirror our delivery in the Northwest region. And since January and the launch, we've had nearly 600,000 clinical pathway consultations across the country. From a Northwest perspective, since January, we've had over 220,000 patients have been supported via Pharmacy First through the 3 pathways. And the Northwest has the highest referral rate from GP practice to community pharmacy, which I think is a testament of the work that's been done through the CPCS service and the good quality service that you've all delivered, and also work support from the LPC colleagues and that engagement support. Also, just to highlight as well, so Northwest pharmacies have delivered over 200 blood pressure checks per 100,000 patient population in the Northwest, which is a really fantastic level. And again, identifying people who are at risk and getting those patients treated and supported. So that's a really good level of service. Just to give a recap, Ray, though, our colleagues will cover this in a bit more detail in terms of the rejection elements. Obviously, the Pharmacy First service is an enhancement of the former CPCS service. And I think just to reiterate, Ray, so we do have 3 elements to the service. So whilst there's been a lot of noise, and rightly so, about the introduction of the 7 clinical pathways and the new service elements, we've also still got the minor illness elements as well, which is the former CPCS service, where you can have referrals in, as I'm sure you'll be aware, from 111 GP and UEC settings. Also, we've got the urgent medicines repeat supply service, which referrals can't come from general practice, but can come from 111 and UEC. And I think what's happened over time, colleagues have become that focused on the new clinical pathways. I think some people are actually missing the opportunities around the treatment of minor illnesses. So we just move on to the next slide. I've taken this has been taken from one of an NHS England presentation, but it's a nice, helpful side-by-side comparison of the 7 clinical pathways, but also the excuse me, the range of minor illnesses and common conditions that can be treated. So obviously we've got the 7 pathways on the left-hand side to give you an indication of the conditions and the age range. The table on the right-hand side gives you a good overview of the types of minor illness that you can manage and support through this service. It's not an exhaustive list, so these are just examples of the general conditions, but anything that you feel competent and able to treat that's referred into you can be managed through this service. Now, also, each clinical pathway do have inclusion-exclusion criteria. We've added a link to the slides just to help refresh people and support. But one key point to really try and highlight to people, if any referred patient that is sent to you that could be a clinical pathway patient, but once you review them, you find maybe they don't fall into that criteria for a clinical reason, they're outside the age range, they could be managed via the minor illness route. So that it may be required that a patient, for example, a UTI patient may find they're diabetic, so you have to refer them on. Well, you can make that onward referral to another prescriber, to a GP, but that would still class as a delivered service. I think it's a really important element to remember, I think, which people think have just got a little bit lost in the pathways. I think, colleagues will come on to a bit more detail, but it's really worth highlighting in terms of support and how we deliver this service. Now you can maximise your delivery and also your income from the service as well. We can move to the next slide, please. I won't spend too much time on this slide, but again, taking this from the service specification, just as a refresh and reminder to really highlight the different referral routes in and the different service elements. Now, I know LPC colleagues have done simplified versions of this pathway just to really indicate the 3 pathways, but this is a really helpful tool just to emphasize how you can manage those patients and the different options with them, how you can the interplay between the pathways, which is really important. Just another element I've been asked to touch on by colleagues as well is the data quality element. As we're now getting data through to review, it's really important that when you're completing your consultations, that you can try and you make sure you capture the best data quality in terms of how you're recording that patient consultation, getting an accurate record, which then feeds back to the GP through the post-event messaging. So it's really important we can try and avoid using default codes or just selecting the first drop-down menu on your computer system. Another key element as well, but particularly around the PGD supply element, is making sure that you're inputting proper quantities. So the key thing is make sure that you're inputting the correct age, sex, and quantities into those, so that will determine whether it's an appropriate supply or not. And we have found some examples. So instead of putting an accurate quantity, people are putting things like half a pack, and if you put 0.5 of a pack and you not put the quantity correctly, sometimes that translates through as half a tablet and some of the pathways. So you need to really make sure you put the correct quantities through, because that can impact on what you're funded and paid. So that data quality is also really important as much as how we manage the referral. If you can go to the next slide, please. This also brings me on to the key message. I'm sure you would have seen the communication that came out on the 24th of June, last couple of days, that's been sent out to all community pharmacies. It's highlighted an issue with particularly the farm outcomes platform and a technical issue. So effectively, where you've had a situation where the GP practice haven't verified their email address, it will not automatically send that post-event message to the GP practice, and a message will flash up on your screen to say you need to then send by another route. Now, this could be an alternative route, either via printing off and posting it, print off or take it around to the surgery, or save as a PDF and attach it to an alternative email address. But as part of the service specification and that messaging process, you are required to ensure that you send the post-event message via another route if required. And what's happened is you also need to tick on the system to verify to the system that you have done that action. Otherwise, the automated message will sit as a background message, and that'll build up as a backlog. In the event that the GP practice then verifies it, a backlog and a huge amount of message can be sent through at one point. So we have a mixture there of issues where a huge amount of messages can be hit the GP practice inappropriately, or we've had significant delays if messages haven't been sent. So a lot of work's ongoing now between national team, region, ICB colleagues and LPC colleagues to support how we manage historic messages. We will be linking in with pharmacies where there's particular backlogs on the systems, how we can support you and work with you to get those addressed. But going forward, it's really imperative, if the message flashes up to say you can't send the message automatically, the notification, you need to then send that by an alternative message to GP practice. You also then must click on the system sent manually to ensure that goes through. Also, you need just to note as well, and again, I'm sure a lot of colleagues are aware of this, if there's urgent clinical information that needs to be sent to a GP practice or referrer, this should be done via a locally agreed pathway, and it could be a locally agreed referral pathway, separate email, telephone call, however best works for yourself and your local systems. But the post-event messaging should not be relied on just to relay urgent clinical information, particularly if you need to refer someone on for further clinical input and support. Okay, if you go to the next slide, please. Just a bit to pick up now in terms of elements of some developments. So a part of the Pharmacy First and the primary care access recovery at work with the transformation of digital pathways. I'm not going to go through this in detail, but obviously just put this slide just to highlight to people the ongoing work. I'm sure you'll be aware of a lot of this work. So key areas around improving referrals to community pharmacy, providing access to patients through the GP Connect access record, which is now launched for the Pharmacy First in some areas. The GP Connect update record to streamline how the GP record's more easily updated and following your consultation. And again, this will help us resolve some of the post-event messaging issues in the future. That work's ongoing now, and that's being rolled out as we speak, and work's ongoing through your system suppliers to make sure once they're ready to go, that will start flowing through to GP practice. But the other key thing, which you should have had information recently, is the development of the booking and referrals, or the BAR standards, which will support streamlined referrals into your pharmacy. So we just go to the next slide, please. This just gives you a bit of an overview, really, of what the process is and the benefits of the BAR standards. So really, it's initially going to support for the minor illness and clinical pathways of Pharmacy First, and it standardises and streamlines the way the referrals are sent by general practice into the community pharmacy, into your workflow. So again, helps that digital patient journey, and also helps the enabling expansion of how referrals arrive into your workflows in the future. So rather than people having to look at emails and things of that nature, it will go, as it's developed and worked through, help really streamline that process. Have the next slide, please. And then, so, excuse me, this just gives you a bit of an overview, really, of the type of information that will be sent by the BAR standards. So particularly key elements would be patient demographics, a lot of the legal information, the presenting complaints and issues, a bit of a clinical narrative, full details of the GP practice, and then key referral details as well. So that will really help support you in the patient journey, and that will flow through into your workflow to reduce the need for people to have to copy and paste information. If you need to link back to a practice or to a referrer, you've got all that key information there. It'll really help support streamline that process. And we go to the next slide, please. So again, this is just really highlights the some of the benefits for community pharmacy. Key element really is saving time, reducing your admin burden, and improving patient safety, but also improve your patient experience, particularly around the consistent structured information flow into your system. So this is being rolled out currently. Again, you'll get more information as it comes through, but it'll really help support your process. So go to the next slide. So really, just again, to support this process, really, the key thing really is confirm which IT supplier you use for Pharmacy First. So this is where the BAR's information will come into. Refer to your IT supplier for specific guidance, any training elements, and they'll let you know when the system goes live for those suppliers in particular. It's making sure that your staff and colleagues are trained up and they complete the training so you can use the functionality correctly. And really, again, just supporting to the 7 clinical pathways and the minor illness conditions. I said that particular slide, really helpful little overview shared before. And also, again, developing local processes. You can triage people, complete the PDS checks, and then you can also assess consultations and complete them thoroughly. So again, this really shows some of the key actions and the benefits of the BAR standards. Other information has been sent out directly to pharmacies, and there's a couple of links, and again, the slides have gone through, so there's more information there for you. And then if you go to the next slide, please. And then just from yourself, Ray, the last element just to pick up on another development. Again, information will have been shared out with LPC colleagues and cross systems. I'll put a link on this slide that you can access later on. But effectively, NHS England have now funded for this year small amounts of resource to helping establish community pharmacy PCN engagement lead roles. Not too dissimilar to those you may remember from the Pharmacy Quality Scheme a number of years ago. There was some support then. It's a similar idea, really. So it's not a huge amount of funding. It works out just over £1,000 per PCN per ICB equivalent. And at the minute, it's only funding for this financial year. It's being managed through our integrated care board. So the community pharmacy clinical lead colleagues, that'll be the key people who will be involved in working in their systems and with LPCs to look at how they can best deliver this role and utilise that resource to support you. If it was given out as a £1,000 per PCN, so the average would be the equivalent of about 8 hours of resource per quarter. So it's not going to resource a full-time pharmacist, the engagement need per PCN. It's not going to resolve all pharmacy issues, but some of the key expectations really are that this will support the pharmacy access recovery plan elements. It'll support that regional implementation and delivery. The development of channels of engagement between pharmacy and PCNs, and also strengthen their relationships, and in particular strengthen relationships between GP practice and community pharmacy. There's a good opportunity for this to be utilised to bolster existing processes, roles, and existing relationships. But as I say, it is a relatively limited resource. It will not be a panacea that cures all issues, but it will certainly help some of the key engagement points. And I say your ICB and LPC colleagues will be working to develop how that's best utilised. So again, so Richard, thank you again for joining this evening. I'll pass on to one of the colleagues to take the next section, but I really do thank you for all the hard work that you're doing and out there. I know to appreciate a challenging environment at the moment. I think so. Just passing on to Pam Sue and Louise Gatley are going to take the next section about the review of referrals.
Hi everyone. I'm hoping you can see me now. Someone say yes? Okay.
Yes, we can see you.
Yes, that's fine. It's because I don't appear on my own screen, so it goes a bit weird for me, Zoom. I do apologise. So what we're going to look at now is rejected referrals. So, I mean, community pharmacy has been doing an amazing job with this service. And I think it's testament to the NorthWest region, the work that went in through TCAM initially, then CPCS, that morphed into Pharmacy First, that we are performing so well in the national stakes, if you like, to deliver this service to patients. And ultimately, it's our patients in the NorthWest who are really significantly benefiting from this service. So we're going to have 4 slides, which I'm going to do the first 3, and Louise is going to come in the last one. But this is a piece of quality work that I've been working on in Cheshire Merseyside, and there have been equivalent pieces of work in Manchester and South Lancashire as well, looking at how we can really support our pharmacists to, 1, understand the service, and 2, really work on how they deliver it to the best of their ability and the best quality outcomes for patients. Sorry, my screen's just gone off and I had my slides on my other screen. There we go. So Adam, if you can go to the first slide, please. So we started looking at rejected referrals, and the reason we looked at those as you understand, when you have a service that where there's interface between the different sections of primary care, so in this case GP to community pharmacy is the major referral process, where you get issues tends to be where there's rejections or service non-completion. So we looked at that as a piece of quality work to understand why we were getting rejections and what we could do to input into the service and input into our stakeholders in terms of resolving some of those barriers. It also tends to be if you've got a reluctant practice, let's say, if they receive rejected referrals, it tends to be one of the reasons they will cite when they say that the service isn't working or the pharmacy isn't delivering. And it doesn't really matter the percentage. It's the old adage of if you have a bad experience once, you'll tell 10 people. You know, if you have a good experience, you might not tell anyone. So we had to look into the rejected referrals, and what we can see is roughly about 20% of referrals into Pharmacy First, and in the main, these are referrals from GP practices, are rejected. So I went through, and my colleague Louise went through a vast number of rejections and looked at the free type box on farm outcomes, which gives us some background and information regarding those rejections and the reasons behind that. And it was quite illuminating. What we actually found out, so Adam, could you just go back to the last slide just before I come on to that one, sorry, is that we had loads of obviously non-contactable DNAs. And the first thing I'd say about that is if you're having a DNA or a non-contactable, when you do your rejection, of which you would have to then go on to do, is please indicate that really clearly to the GP. So, you know, if you have phoned them 3 times and you haven't managed to get through, query whether the mobile number is correct, that type of thing. So put the information in your rejection so the GP practices can potentially act on that. Because if you can't get through on repeated calls, neither can a practice, and that might be the only emergency number they have for that patient. So it is worth highlighting that back to the practice. What we actually found was a lot of the time, interaction had happened between the patient and the pharmacy, and the patient had actually had a full consultation, but for various reasons the pharmacy had not then gone on to claim for that. So actually what we found is the rejection indication that happened may not have been the appropriate sign off in response to that interaction with the patient, and so the wrong message went back to the practice to say almost that patient's been rejected, not been seen, when they actually had a full consultation, and also the pharmacy had not claimed their contractual money for that as well. So the pharmacy were losing out in terms of their service delivery. So next slide, please, Adam. So, and you will get copies of these slides. So I know this is a bit wordy, so I do apologise. But this was giving an example of real life rejections and why they'd happened. So what we found was a range of things. So either people saying this patient didn't fit with the pathway, they were too old, too young, had contraindications. And as Steve pointed out earlier with his workflow, and my third slide is the workflow that I'll go through with you in detail, is that if a patient doesn't particularly fit a pathway, they can be treated under the minor ailments. Now that is only for referred patients. So if a patient walks in off the street and they don't fit a gateway criteria, you just deal with them as an OTC patient as you normally would. With a referred patient, if they don't meet the gateway or there's an issue with them in terms of they're too old or too young or they don't fit the PGD, you can treat them under the minor ailments element of this service as you would have done within CPCS. You can then either treat them as an OTC patient if that's appropriate within pharmacy first. You can refer them into a minor illness service. So if you have a minor ailment service that is funded within your area, you can use that in order to support and treat patients. And obviously there is the escalation route, whereby if a patient isn't fitting a PGD because they are have significant concerns that they need to be seen by a separate prescriber, then you would do the escalation. And those are different to rejection. So what we were finding is there was patients that had probably gone through that whole process. You know, you'd said to them, oh, well, you know, you're over 17 years old, so we can't really treat earache, but this is what we can do for you in the pharmacy. They'd had a conversation with the pharmacist. They've been offered OTC and potentially bought OTC support. But instead of documenting that and signing it off as a CPCS element, a minor illness element, they've been rejected. So again, we don't think there's a lot of patient risk here, because actually from the information we were getting through on the free text boxes, it looks as if the patients were absolutely being supported and being treated. It's just that the sign off of the farm outcomes module reflected a rejection, which didn't actually then reflect what had happened to that patient. So this is really, really important, because one, the more rejections we get that are showing you know, the national team won't go into these reasons. They won't take the time for, you know, that I've got or Louise has got to go through the reasons. So we know not all the rejections are true rejections. So in order to prove worth of this service and actually reflect the absolute benefit you are providing to those patients, bringing those incorrect, if you like, rejections down is really, really significant for the overall service. But it's also really good in terms of the PR element of it, because if we can reduce those rejections down, it stops that grind at the interface where GPs are saying, oh, well, we send people through, but they bounce back, because actually what they're actually only then going to see is the real true escalation and escalated patients rather than rejections. And that will do no end of good for the promotion of the service and really demonstrating the quality work that our pharmacies are delivering there. So as I say, there's a range of reasons, but a lot of them fell into the fact that they were out with a pathway. The pharmacist potentially had treated them as a minor illness, but then hadn't reflected that in the sign-off of the consultation programme, if you like. So Adri, if you can go on to the third slide for me. So this is a very simplified view of what Steve showed earlier. So as you say, if a patient comes in and presents on the orange box on the right-hand side, if they present, they can either gateway meet or gateway not meet for the Pharmacy First 7 conditions. But that is different to what you will see if a patient is referred in. And this is one of the reasons that we are pushing formal referrals very significantly with our GP colleagues, because it gives you more options as a pharmacist as to how you can treat and support that patient under this service. So they can either obviously be referred in for urgent repeat meds. Now that wouldn't be through the GPs, but that could be through urgent care or NHS 111. Thank you, Adam. I see your little red dot doing its thing. That's brilliant. You can get a patient being referred in for a clinical pathway, which is the pink box. And in that case, they either meet the pathway and they move on to a clinical pathway consultation. But if they don't, if the gateways are not met, you can move them almost what we call backwards back into the old CPCS version of the service. And that's the bit where you can treat any of the 7 pathways under a minor illness referral if they don't meet the gateway. So if someone doesn't meet the gateway for example, as used before, earache, are there options you can give them? If they don't make the gateway for UTI, are there OTC options that you can give them? And even if it's a given, so providing them in the interim with the safety netting of if this doesn't work, you need to go back and see your GP, or you could treat them as an OTC patient, but also push an escalation back to GP as well, as long as you detail why the escalation is appropriate for that patient clinically. But in those cases, you've actually delivered the whole service, you've supported that patient, and you can finish that off as a claimed element of patient care, whereas a rejection doesn't give you that claimed element of patient care. It's just rejected out the system. So it's really important for yourselves as service providers to claim appropriately and have remuneration. It's also really, really important for the overall service to reflect the work that you have put in adequately, so that the GPs, the national team, anyone like myself looking at quality work can absolutely see that that service has been delivered in the rounds. So for the 7 clinical pathways, you can't always revert to CPCS. And we also had quite a number of referrals that were rejected because I think the pharmacy had got into their headspace. The 7 pathways were so clear in their mind that anything out with that wasn't being treated under the minor illness and was being rejected. So say anything that was referred through in CPCS, verrucas was one of the examples we put in the previous slide. So it could be anything that a GP has referred through to you, believing that actually community pharmacy, you are well adequately served to treat this patient with this condition, were being missed because they weren't, when they got to the pharmacy or the referral got to the pharmacist was only seeing in their head the 7 common conditions. So please remember that this is a very wide-ranging service. It hasn't narrowed it down from the previous CPCS service. It's only built on that. So anything you treated before under CPCS can still be treated and still claimed for appropriately under a referral programme. It's only that the seven clinical pathways have expanded your repertoire, and it's an expansion, not a subtraction, if you like, of that service. So please remember that this service is an entire patient offering, and please reflect when you are completing your consultations online, making sure that where you have delivered a minor illness referral, that you're reflecting that and not rejecting them, because that's really significant in terms of the overall service delivery. If you go on to slide 4, Adam, I think Louise is going to talk us through the final slide.
Yes, thank you, Pam. I'm sorry. So before talking a bit more about the rejections, I do think it's really important to remember that when a GP practice makes a referral, that they are transferring clinical responsibility of that patient to you at the pharmacy to look after their patient, and they're expecting that patient's care to be of a similar standard to the standard they would have got had they seen a clinician in general practice. So it really is very important that we see as many patients as we can and either complete a consultation on that episode of care with treatment under the clinical pathway or treatment for a minor illness, or we complete a consultation and we escalate the patient back to the GP by phone or onto another healthcare professional if it's something that we can't treat. We do know, after speaking to some GPs, that they don't always prioritise reviewing rejection messages. So sometimes that really important message that you're putting in the rejection notes might not be seen the same day. And that is something that does worry us, because obviously some of those patients do need to be seen. And all we can see is that a rejection message has been sent to the practice. Some of you may have made telephone calls alongside that rejection message, but it isn't something that we can see has happened. So using that rejection message as a way to refer a patient back who requires a consultation really isn't appropriate. So when it comes to looking at the uncontactable patients, or those that didn't attend, either didn't attend appointments that had been arranged or didn't attend at all, we do see some real variation, and we see some pharmacies rejecting far fewer referrals as an overall percentage than others. Now, that could be down to patient populations and demographics in some areas. Some patients may just decide they don't want this service after they've spoken to the practice, and they just don't answer the phone because they don't want to have that uncomfortable conversation. But often it seems to be that the approach that the pharmacy takes in contacting the patient is different. And as Pam alluded to before, we can see from the information recorded that those with lower rejection rates will usually have recorded and made several attempts over the day to contact a patient, and only as a real last resort mark them as uncontactable, either last thing in the day or even to try again the following morning just in case, and just as a final chance to try and capture them and get them in for an appointment. Whereas we do see other pharmacies who may have only made one attempt before rejecting very quickly after the referral has been made. Sometimes the referrals are rejected within a couple of hours of them being sent, which doesn't often give the patient the opportunity to finish work where they may not have been able to answer their phone, or to get into the pharmacy after work. And this really is where we want you to think about using your wider pharmacy team to help. They can really support in the work around the main service. Obviously, that needs to be delivered by the pharmacist, but where patients need to be contacted, where appointments need to be arranged in pharmacy, and where multiple calls sometimes need to be made to patients, working with your pharmacy team to make those calls, monitor farm outcomes, and either reject appropriately or support them into the pharmacy is really important. So please do work with your pharmacy team. Don't take on all the work yourselves as pharmacists. It does need to be shared, and there are people there, hopefully within your pharmacy, who can help with some of that. There are those some situations where rejection is appropriate. So, for example, some practices will refer patients for the wrong service, and we know that some of them will keep doing that. So they'll send hypertension case finding requests on a pharmacy first or contraception. And we do ask that you please feedback to the practices if they are doing that, and explain which way they should be making those referrals to you. If it continues to be a problem for you, you know, ask the LPC for some support, and we can certainly help liaise with practices on that. Some other examples that we've seen around inappropriate rejection. So appropriate rejections would be where we've had practices who've sent requests for advice on prescription medicines. We've seen obviously test messages that might come into you in the pharmacy where a practice is just testing the system out to see that it works. All those are appropriate, but we do, like Pam said before, we do want to try and maximise the number of patients that are seen who should be, and really reduce those rejections down. And that ends this section. I will hand over now to T and Andy, who are going to tell us about their experience of the service so far. Thank you.
Hello.
Hi.
Hi. I'm going to start, Adam, if I can have the first slide, please. A little bit about the service setup and keeping it running. So the next slide, or the next part of it, thank you. Most of this will be done already, but because we've got new pharmacists coming through, I think it's important to say that anybody going to complete the service needs to be trained appropriately. So that's using the Clini skills or CPPE. Obviously using an otoscope is new to all of us, so practicing with the otoscope on family and friends is a very good idea before you first stick it in a child's ear. And also it gives you the confidence that you can do it and you can make the mistakes on them. Also using a tongue depressor, that's not easy, and that needs practicing as well. Make sure the PGDs are all printed and signed. You have a really good master sheet for signing the PGDs for locums, so they can just do one signature for all the PGDs, which I think is ingenious. Make sure the flowcharts are laminated because they get very scruffy very quickly, that they're readily available, especially for locums or people working that are not usually there. Important to have the stock available because there are a few items where we wouldn't normally have them in the pharmacy, like Otigo or Otigo, Cristicide, and there's been some items that have been out of stock, like mometasone, fluticasone. So we've put all of those bits of stock into a basket separate so they can't get used for prescriptions. Have all the target and dermatology leaflets printed ready to be used, because it's a nightmare if your printer breaks or you can't get access to it in the consultation, and replenish those as you use them, because you do go through quite a lot of target ones, even if you're not meeting the gateway on the clinical pathways. Make sure your consultation room is set up, so you've got a supply of tongue depressors, your ear thermometers working, your otoscope heads are there, thermometer covers are there, everything's got a battery and it is actually working. On your PC, on the computer in the consultation room, please make sure that you've got Pharm Outcomes or whatever system you're using up and running on there. You've also got access to the summary care record, which you will need for some of the services. Adam, can I have the next slide, please? Thank you. And the next one. Sorry, we split it. So this is a service that I think is going to be so good for pharmacy profession, provided we do it properly. So it is really, really important there is consistent delivery of this, and that every pharmacist that comes in and works in your pharmacy is ready to use it, and that they have the logins in place, including the dreaded MFA with the multi-factor authentication. I've had to get my locums actually into the pharmacy to get it working on Pharm Outcomes. I've not been able to do it without, so it's really important to have that in place before people come. Communication with staff is key, so that they know where everything is. They know if a locum comes in, that they know what system you use, is Pharm Outcomes or Positive Solutions or one of those. They know all the logins, they know where everything is. And that also they know what the 7 conditions are. So if they're treating with somebody over the counter and they think, oh, hang on, this is one for the pharmacists, they know to refer and let you know that this could be a clinical pathway. Communication with GP practices is key. I found this more difficult than Andy has, because he's more close to the practices than I am. But a pharmacy-friendly surgery would be really useful to speak to them about this and to drive referrals. Advertising the service is important. It did get advertised initially by the government, but then that sort of has died down a little bit. But if you put it on your website, on Facebook, on X, digital screens, posters, that kind of thing, that will really help with trying to push referrals or trying to push people coming into the pharmacy. I just had a little bit there about the GP and the NHS 111 referrals, both manuals and clinical pathways, to obviously not get sidelined by just clinical pathways, that it's both. And then make sure you permit all referrals if you've dealt with a patient, because only reject referrals if the patient has not been in contact. And it also means that you're going to get paid, which, as the numbers of referrals go up to reach your £1,000 target, that will be really, really important to try and get there. Over to you, Andy.
Okay, thanks, Adam. I think in terms of delivering the service, the way we do it has changed since the end of January. Most of that is due to confidence of the pharmacists in providing the service. The sheer dread at the end of January, beginning of February, when a parent dragging a small child into the consultation room with a small ear, with a sore ear for us to have a look at, But once you've done a few of them and you get into the swing of things, I think you develop some confidence in providing the service. We're tweaking the service as we go along. So a good example of this is we are now trialing in the pharmacy a contact form for patients to fill in when they want to have a consultation with the pharmacist. We particularly use it at busy times, but we're getting to use it more regularly now, where we take the details of patient's name and address, and we have tick boxes on the form for all the pharmacy first conditions or EHC or other minor health conditions or medication queries. And what that enables us to do is place the patient in the prescription queuing system, if you like, so that people who are still waiting for prescriptions are seen in turn, and people waiting for a pharmacy first referral are seen in turn as well. And it allows the pharmacist to put those people in the right order. What happens is, more importantly than that, it allows us to go into the consultation room. We got the details of the patient. We can log on to Pharm Outcomes. We can find the patients on there, prepare for the consultation. So, for example, for sore throat, we can find our otoscope, ear thermometer. It allows us to check the stocks of medication to make sure we've got them to hand. And it means that during the consultation, we can devote all our time to the actual consultation and information gathering from the patients. And the process becomes a lot smoother, more streamlined, and a lot more professional. I remember when we first started doing it and you went into the consultation room, and we had maybe a sore ear, infected ear. We were looking for the otoscope, we couldn't find it because the last person had moved it, and all those sort of things. So that couple of minutes of preparation time is key. So you just prepare for what's going to come in front of you. There's slightly other changes as well that we've trialed a couple of fever pain clinical tools, scoring tools. And we've settled on one now where we can copy and paste all the information back into Pharm Outcomes. That's handy because it saves a lot of time writing information into the record. We also use text messaging for patients. So most of the triage referrals come in from the practices first thing in the morning or early in the morning after the phone call, the 8 o'clock phone calls. So we tend to get people in first thing in the morning, but if they don't arrive, we tend to text message them just to explain what the service is and to contact us so we can have a discussion as to what it is they require. One of the things that struck us is how much we are now doing and more confident in doing delayed prescribing strategies and self-care as a first recommendation. I think in the beginning, we didn't think that patients would accept this. As many patients see it as an antibiotic service. I had a patient on the phone today saying, oh, I'm coming in for my antibiotics, and we had to explain that this wasn't the service. We have to follow the clinical pathway. And I think it's really important to explain to patients what the service is, what the service isn't, because that's important for changing people's perceptions of the pharmacy service. This isn't just where GPs offload patients to give antibiotics. It's a full clinical pathway service. Clearly, delayed prescribing strategies are good for antibiotic stewardship. And this also differentiates us and the service from a GP service, because there's nowhere in the world these days that a GP is going to say, if you want to come back in 3 to 5 days, if it hasn't cleared up or the condition's getting worse, then, you know, you can walk straight back in and we can follow the pathway again. You know, GPs can't do that these days, but we can do that. And people are usually quite happy with a self-care recommendation if they know that in 3 to 5 days, they can walk straight back into the pharmacy without a consultation, without an appointment or without a referral. And then we can take them down the next route, if you like, in the clinical pathway. And we found that quite a lot of patients are happy with that. And what it actually means that, you know, we're happy because we probably won't see them again, because we know that a lot of these conditions are self-limiting. The patients are happy. And of course, if they do come back after the second consultation, you know, we can claim another consultation fee for that because we're providing that service to them. Any safety netting information you give is really important. It's really important to record that on farm outcomes or on your clinical record, just to have that in the system as well. All the time, there are improvements in systems and clinical systems. So we're now being offered video consultation systems, new ways of booking in patients for the services. These things are being offered to us daily, if not weekly, via third-party companies. So there's a lot of interest in this service, and it's a really good. We're finding it is a really good clinical service for our patients. Anyway, thanks, Adam. How to improve? How are we going to improve the service? I think one of the things that I think has just been discussed was about how we're escalating patients that need to be escalated back to their GPs. It's quite difficult. It's for some pharmacies who don't have ready access to their local GP practice. Luckily, I work right next to a GP practice, so if I can't get through on the phones, I can just walk in the door. But most pharmacies aren't like that. So we need some kind of consistent method of contacting GPs to escalate patients back into the system if needed, whether that's backdoor phone numbers or designated email addresses, or some way that ensures the patient isn't being pushed around, pinballed around in the system. As everybody has said, GP referrals are vital to the success of this service. I think, as the number of referrals go up and we have to make 30 a month to get this £1,000 a month, referrals from GP practices are vital. I've got 2 practices near me. One of them is really good, really switched on at referring from their triaging in the mornings. And so we get a host of referrals in the morning. And the second GP practice, we've had absolutely nothing from. So I think communication is key. Find some friendly staff in the practices, have a discussion with them. I've already done that myself this week. And what they're saying is that the GPs know the service exists, but don't quite know what to do with it. They've had quite a lot of new staff recently. And so there's training issues around new staff. So it's worth making those contacts and discussing those with the practice, just to ensure that, you know, they're consistently referring into pharmacies. I absolutely concur with what was said before. They've got a list of their 7 clinical conditions on their wall that they know they can refer into, but they don't tend to refer any of the other minor illness conditions. And that's a shame, really, because what tends to happen is patients will go to the GP practice and the staff at the GP practice will say, just go to the pharmacy. They don't refer in this sort of accepted method, so they don't come through the route of the pharmacy first route, if you like. And so patients aren't getting that extra service. Although we're obviously treating them as over-the-counter patients. So that's really important. So it's important to try and find some pharmacy-friendly staff within those practices. And they really are interested when you sit down one-to-one and talk to them about it. So it's definitely worth having those conversations. again, rejecting referrals, that puts GPs off. We've talked about that earlier on. And during the election, which is coming up very soon, I think, if everybody knows, all the parties are talking about increasing the number of conditions, for pharmacies to treat. So it's, it's a real positive, but it's important to get these processes streamlined now. And so we can, when these new conditions come on stream, we can make a great success of it. Thanks very much.
Thanks, Dee and Andy. So if I can hand over to Amol.
Hi, evening, everybody. I'm just going to share my experience. I work for Well Pharmacy in quite a busy pharmacy, and some of what I'm going to say is echoing what the other colleagues have said on the call. So obviously we started with this service a while back, and it's been really successful for us. And I'm just going to bullet point key things that I think are really important for us as pharmacists to be doing. And the first thing is surgery engagement that we've talked about. And that engagement is about, are we going to speak to the practice manager? Are we getting involved in the clinical meetings? Because that quality of that interaction with the surgery is a difference between you getting maybe 1 or 2 referrals or a whole host of referrals. And it's us moving away from being checking boxes or just giving prescriptions out. And it's, in a way, being a bit of a salesman, which is, this is what we can do for you. So, for example, we can take care of people with sore throats, or we can look at patients with earache and a whole host of conditions. And this frees up time in your surgery to deal with patients that you feel that need more dedicated care. Once you've done that, it's not about having one conversation. It's going back each week and saying, look, this really went well. I saw 6 prescriptions for a UTI for a female, 23. Feedback and review how you're doing with the surgery. My surgery have really embraced it, and it's down to us to sort of explain to them how we, or me as a pharmacist in well or next door to my surgery, how I can extract workload and pressure they get first in the morning, where they've got 300 phone calls, they're all demanding an appointment. These guys can be quite effectively referred to us. It could be a verruca or it could be something else, but it's really important for us to engage with the surgeries. And it's not just once a month or once every 3 months. Is if you're close to the surgery next door, possibly go and see them every week, every day if you can build that relationship and say, that was great, how did that go? And also ask for feedback back, saying, what did you like about it or what didn't you like about it? Because if we don't understand why they're not referring or why they've stopped referring or they continue to referring, is share best practices. But building on that is, it's down to us. We've been given this gift of this service to take us into a more clinical role, which we all went to university for, is your colleagues. Have you got the right skill mix? So I looked at my team. Do we have the skill mix? Because we as pharmacists, we have to spin 6 or 7 plates a day from NMS through to doing a flu jab when it's flu season. And then we're getting these referrals through. So we're masters of trying to keep 6 or 7 plates spinning. And your team is critical and vital for you to be able to deliver this effectively and safely. And I say to my team, make every contact count. And what I mean by that is, if someone comes in and picks up a box of cystitis relief sachets, take that conversation further. Why are you buying that? What's it for? How long have you had the symptoms? And at which point they will refer to me, say, Amol, I think this is the individual you might want to speak to. So yes, we've got to get the referrals through, absolutely. But it's also a big part we can play is making every contact count, which means that if Flossie walks in off the street saying, I've got a sore throat or my little child's got earache, instead of running to another service, they're coming to us and we're converting them into a clinical pathway or a minor ailment, because it might be Difflam spray they need or whatever. So it's about educating our teams. And like my other colleagues have said on a call, it's about how we get the service out and people know about it. And it's the best way is to deliver it, because word gets out that, oh, I went to see this pharmacist the other day, I had insect bite, brilliant. He told me to come back the following day if symptoms got worse, which I did, and he gave me some flucloxacillin and it worked. So we're ambassadors of making this service work, and the people on this call must be passionate about it. That's why on the call. And it's, first of all, surgery engagement key, your staff's key, and making sure your staff are competent to recognise when to refer, and aware of the clinical pathways. Now, we have quite a few important tools in our boxes. So those of you aware of Socrates and ICE, and I use ICE a lot because once you're in a consultation, you can be put under pressure to prescribe an antibiotic. Like my other colleague just said, that their expectations are, I've come in for antibiotics. And hopefully all of our teams, and also we're all antibiotic guardians, and we use targets. So it's about understanding what they want to do, and don't feel pressurized to give antibiotics, because earache in children is proven a statistic that 90% will clear up on their own. We only prescribe antibiotics because we're fear of mastoiditis, which is extremely rare. So don't feel pressurized into, say, throwing antibiotics at a condition at the behest of a patient's request. It's about understanding that we are antibiotic guardians and stewards that say, look, give it a couple of days, come back to me, and we can treat that condition for you. But a point I want to raise is the quality of information we put on farmer outcomes is critical, because if we don't write what happened, it never happened. So if someone presented with insect bite and you've said to them, use some hydrocortisone cream, it doesn't look too bad, but come back tomorrow if that swelling gets worse or you're starting to feel ill. If that is not recorded and that suddenly turns to a situation where sepsis occurs, it didn't happen. So it's really important that we record everything we speak about and we write it concisely without using any short codes or any abbreviations. It's clear as day as what we've done in that scenario. I just want to bring a bit of a broader picture into this, which is a success of mine, particularly in Leeds, is we get all the APBM referrals. Again, go to the surgery, say, look, where do you send your APBM patients? Oh, we send to hospital, takes 2 weeks, 3 weeks later, we get the results. We're in a unique position, just like the other colleague said, is you can come to us the following day, we can see you. So I tend to turn around the APBMs and I get about 5 or 6 referrals a week in 48 hours. The patients treated, dealt with, within, I'd say, 72 hours, they're on either felodipine or whatever, and which we can then engage them into the NMS service. And it might be not a patient of yours, so you might have gained a new patient, which you can take pride in taking care of. Again, contraceptives, again, I went to surgery, explained what we can do. And as a result, the surgery do not resupply any contraceptives at all. So every contraceptive patient now is referred to me to deal with. And it's on the back of a conversation, which I thought was quite as enlightening, which what I share with you, which I had with the doctor across the road. He goes, look, Amel, we're not an urgent treatment centre. I said, okay, I get what you're saying and your frustration. So what are you trying to say to me then? He goes, well, why referred that patient back? I said, well, why are you seeing patients for X, Y, and Z if you're not an urgent treatment centre? So let's get together and decide at triage who should be referred. And it's really key that, yeah, the practice manager might know or the doctor might know about service, but does the receptionist understand the service? So when someone rings up in the morning and say, I've got a sore throat, and they're booking them in, or a 4 or 5-year-old's got earache, they're booking them in, they are referring to us. So as you know, the pressure on A&E, primary care is immense. We're here with this service to alleviate the pressure. And I think if we do it well and execute it well, surgeries really do get on board with it. And I feel it's down to us as ambassadors going forward, ready for 2026, that this is a gateway towards prescribing in the future. And I think it's exciting times, to be honest. And if anyone's got any other questions or views, please put it in the chat. But I find all the service we do, especially Farmers First, is really rewarding as well. I don't have anything more to say, but I'd like to pass it on. I hope that just gives you a short brief, but it's building on what everyone else has said today, that it's a service that's in our hands to deliver effectively, and we can see patients a lot quicker and resolve issues before it does end up into a situation where it needs further clinical treatment. So please, that's the end of my session there for you there, but please take the service with both hands and enjoy it.
That's brilliant. Thanks, Amol. So I'm going to pass over for the end bit through to Suzanne Austin, who's a Pharmacy Services Manager at Cheshire and Wirral LPC. I have seen there's a few questions in the chat. We'll come on to them and I'll make sure we field them to the right people. So Suzanne, over to yourself.
Thanks, Adam. You move the slide on. I'm not sure, after what Amal said, I have an awful lot to add, but we can go through some of these things. There may be a few bits and pieces. So the first thing is exactly what everybody has said: visit your surgeries. If you haven't had a chance to go and knock on the doors, I know you're busy and I know there's plenty of other pressures and other things you could be doing, but it's well worth it if for those surgeries who are a bit slow in this, who are not getting the message that we could really help them get through some of their access targets that they need to get through. Explain the conditions, and it doesn't matter who you talk to. Just start with anybody. If it's the practice nurse, if it's the practice managers or the triage nurses, if GP is great. If you could get in for some of their protected learning time or on their clinical meetings, then that's excellent. And it just starts to develop relationships, exactly as Amal said. So that then if you've got a relationship where they're happy and with your referring things to you for pharmacy first, and the way you're treating them, handling them, and you're giving them, sending them back only the ones they really need to see, you'll start to develop that trust and that relationship. And then maybe when you've got a query because something else, there's another shortage and you need another prescription changing, they will say to you and they'll answer your queries a lot quicker because, oh, it's Amal around the corner. Oh, right, it must be important. He will only contact me when it's important, and they're more likely to engage with you and help you out. So it's going to help build those relationships. It would help if you can do to familiarize yourselves with how it works at the GP practice level. So what is this EMIS button that we're asking the GPs to press? That would be brilliant if you understood that. And the way to understand that more is to speak to your LPC representatives. Many of the LPCs have got colleagues who are going out into surgeries to do that kind of training for the practices and help and support them. So if you have got practices who have been a bit slow in taking this up or aren't taking this up at all, contact your LPCs and they can see what they can do to engage with those surgeries on a separate basis to help them. So it's not just you that has to go knock on the doors. They will go in and help train their staff. And a lot of our surgeries have done that. As Andy said before, there's a lot of churn in staffing anywhere, and in GP practices are not exempt to that. So they do get staff that go and leave, so they may need to be retrained. Let's say contact your LPCs to get that support. Check on your referral routes, your NHS Mail, Farm Outcomes, Sedgedem, your PMR system, whatever it is. What we can't afford is for you to drop your ball. These referrals are coming into you, you need to action them. So please make sure you're aware, if you're not going to be there, that your senior staff are aware where all these notifications are going to come into, so any locums on the day can get access to them so that these are actioned as soon as possible. We don't want to be the ones that are making this system look rocky. We want to make sure that we're delivering as well as we can on as we should be doing. Engage your teams. As we've all spoken about tonight, it's not just pathways, there's all sorts of conditions, but do your staff or do your counter staff understand which conditions you can see as part of pathways, which conditions you can see as minor ailment services? Train your teams, get them to understand what it is that you really want to be involved in, what ones that they themselves can treat. A sore throat doesn't necessarily, as we talked about many times, lead to antibiotics, but your counter staff are well able to treat these. Have you got posters up in your pharmacy talking about pharmacy first? Do you put bag stuffers in your prescription bags so that when somebody's coming for what looks like an antibiotic for a UTI, let's be honest, what else would you give trimethoprim to anybody? Put a bag stuffer in so that next time they get this condition, they know that's to come into you. And so they don't need to go to the GP surgery next time. Make sure you're doing bits and pieces like that. Understand where, if you have a local minor ailment service, and we know in Warrington there's about to be a new one commissioned, so understand when that comes in and you're asked to sign up to that service level agreement, get yourself involved in it so that you can treat people who are much lower down pathways, nowhere near a pathway, but need treatment and can get treatment that way, particularly for those of you who are in disadvantaged areas where this kind of access to medicines is really important, and the cost of accessing medicines is something that's prohibitive for some people. There's plenty of work, plenty of resources on CPE's website. The briefing 1024 is the one about briefing for pharmacy teams, but there are briefings on there for your GP surgeries that you can print off and go and take into the surgeries or email into them so that they know what the service is about and gives a start of a 10. Just start those relationships and let's see where it takes you, but it will be a lot easier for you if you have got those relationships. I know it's not easy, but it's definitely the way to go. That's it. Thank you, Adam.
Brilliant. Thank you, everyone. I just want to say thank you to all the presenters, first of all. There's been some really good top tips, really good experiences, and some really good background information and learning shared tonight. We do have a number of questions, so I'll go through them from the Q&A function. I can't quite see what order they're in, so if I do answer them out of order, it's nothing around me picking and choosing. I'm just doing the ones that are at the top of my screen as I go through. So the first one back was from Haroon, which was about when referring back to a GP, is it sufficient to do it just on farm outcomes, or do we need to contact the surgery by phone? I'll pick that one up if that's okay. So I think it was covered earlier. If the hot handover element, if you are merely reporting what you've done, you're reporting the clinical information and informing what safety netting advice you have given, there's no need for that patient to be seen by someone else, then that's absolutely fine for you to close the consultation down on farm outcomes, and that's indeed what you should be doing. If there is a need for the patient to be seen by the GP, then the service spec's pretty clear. You have to hand that patient over appropriately, whether that's by a clinical emergency route that you've got locally that you may or may not have, or whether that's a conversation after queuing up to get through on the phone to the practice. There is that expectation in the service spec that there's a hot handover done for you to arrange the onward care of that patient appropriately. Next one, again, it's from Haroon. So it's around DSPs. We feel DSPs are at an advantage by not being visible online, 111, hence not receiving referrals. What would your advice be? Steve, am I okay to pass that one to yourself around the DSPs and the 111? Because I know there was an update on what was going to be happening with them long term, but I've not seen one for a while.
Thanks, Alan. Yeah, I'm not aware of the specifics in terms of changes or timelines at this time. I know there is work on. I believe there's work ongoing to try and help support that process and make DSPs more visible to people. I think so. That's what we'll do. I will go back and check with my national team colleagues who will be working on these type of developments, and I'll commit to bringing back any further information to share with colleagues as I'm able to. So I'll take that away as well. I mean, I think what I'd suggest in terms of service delivery currently as is, I think the big element is making yourself known, building those relationships with prescribers that you link in with. I appreciate from a DSP perspective, obviously there is also an element of providing services nationwide. And I think key thing as well, I think links into what Andrew and T said before as well, it's making sure that you're advertised that you are providing these services. So you make it clear on your the website and on your advertisement options how patients can interact with you. Make it known through GP practice that you are there, you are providing the service, you are able to support. I think key thing as well, not just with DSPs or pharmacies, it's also making it clear to people that this isn't just an out-of-hours service, that you're able to provide, particularly minor illness clinical consultations. You can provide this service through the working day and support those practices. So it's not just a weekend and evening service as well. Also, I think the other key element is making sure you've got really good access to remote consultation elements, again, to support good quality patient consultations, because again, appreciating it, seeing patients on site at the DSP is not something that is possible, particularly for some of the pathways. So I think they're some of the key things I'd recommend, but I will take away the linking with National College to any further developments on how you can be accessed through 111 online and things of that nature.
And then we've had a couple of other questions, which are I think one's a comment that links into another question. So it's around someone who's getting some very few referrals from GP surgeries. Will there be an incentive for GPs to refer to you? I honestly think they're afraid to send them through. And there's also some elements around GPs being unclear. So there's two things. I'll probably lead off and then I'll open the floor to anyone else who would like to chip in. I think referrals are a few different factors going on that we see in our area. Some of it's GP confidence in the service itself. Some of it's GP and staff knowledge of the service. And if you're not getting very many, I think definitely my advice would be to check with your LPC about what support there is locally, either from themselves, from the ICB pharmacy team and clinical leads, and any other support mechanics it might be. It does differ slightly area per area, and the LPC will be no will know what is available in your patch to support and can escalate any specific issues back to the system if there are people struggling. One of the things we've learned, our contractors have had one of our contractors in a rural area had one of their local practices send loads of referrals right at the start, but then they didn't get the referrals right, as it were. So they were sending inappropriate people that weren't within the pathways. And actually, rightly so, the pharmacy ended up hot handovering an awful lot of people who didn't hit Great Way and they couldn't treat back to the service. And therefore, the practice basically completely shut it off again. Once that pharmacy and ourselves got involved and we educated the practice team, the care navigators, around what they could send and what they couldn't, they've been able to gradually build the numbers up again. And I think it is that local communication, that critical build up around it. If I can bring Louise in first, and then there's another couple of people. I haven't dealt with the incentive, I know, but if I can build Louise in to talk about what's about Halton, St Helens and Knowsley particularly, where that question came from.
Yeah, thanks, Adam. I'm happy to help with that one. I think this is St Helens, particularly St Helens issue that's been raised. And just to give some assurance to the person that asked the question, today I spent an afternoon at a practice learning event in St Helens. I think all practices represented, GPs, practice managers, practice nurses, pharmacists, etc., all there. And gave quite a detailed presentation around pharmacy first, contraception, hypertension. So hopefully that should give some assurance to the practices around what a pharmacist can and can't do, and a recap and to them as to what the services are all about. So hopefully that'll drive some activity. Again, backing up what Andy T and Amal said around visiting practices and engaging with them. I know particularly you've done it before, but doing it again and keep reminding the practices what you can do, I think is really, really important. And finally, from a St Helens point of view, because that's where I think we're talking about, our engagement officer has got some plans to go into practices in the next couple of weeks, particularly in the Newton and Haydock area, to start doing some more practice work with them to try and boost referral numbers. So quite a lot of work going on, certainly from an LPC point of view, definitely in St Helens and within one of the PCNs that I think may be affected. Thanks, Adam.
Thanks, Lou. I've got Pam and then Stephen who want to come in. So Pam, do you want to go first?
Yeah, it's just to sort of say, whilst we don't have specific incentives for the GPs to make referrals, what we are doing is, as an ICB, we are measured against the PCARP measures. So for those who don't know what PCARP is, because that's a very specific NHS England and ICB term, it's about access and recovery. So access and recovery is wider than GP services. So access and recovery post-COVID brings in a lot of community pharmacy services, and we're measured against the delivery of those. So that includes pharmacy first, hypertension and contraception specifically. So what we are now doing, and has only become available in the last couple of weeks, is we now have the data and a very significant data set around this that we are being measured on. I am sharing this with our LPC colleagues, but the issue we have at the moment is the data set is so complex that it's actually quite difficult to navigate. So I'm working with our analysts team at the moment to have a very easy to use, user-friendly, put it all in pictures, put it all in bar graphs or pie charts that our ICB can use at ICB level, at place level and at PCN level, so they can actually see how their practices and pharmacies are performing, and where we've got opportunistic, where we can put opportunistic evidence in to really capitalise. So if there's a PCN that isn't actually delivering a lot of these services, we can start to analyse why that is, and where we've got good practice, share it. So that's a massive piece of work that is ongoing. The analysts are now my best friends, because as a community pharmacist background, my Excel skills are limited, and I don't make pretty pictures with bar graphs, but my analysts do. So I've handed it over to them, and as soon as I've got that to share, it will be shared widely. And I know there's similar programmes of work going on in Manchester and South Cumbria. This is not just a Cheshire Merseyside thing, because at the end of the day, we need this message to go far and wide. So the regional team are asking ICBs to report on this, and the national team are asking ICBs to report on this. So while there aren't incentives, there will be a certain amount of analysis and to understand where there are levels of excellent delivery and levels of less than excellent delivery, and there will be interventions put in place to encourage and support practices and pharmacies to work together. And some of that goes back to the information that Steve gave at the beginning about those PCN lead pharmacists. So we'll be pulling out every tool in our book to make this work. So if you do believe you're in an area that you're not getting referrals through, the first thing I would say is speak to your LP, speak to your practices. That's your first thing. Absolutely. If you haven't gone out and done that, do not rely on them being proactive. Go out and speak to them. If you're getting resistance or you're not getting referrals or you're struggling with it, do speak to your LPCs, because their engagement officers are brilliant and they will potentially be able to give you that support and make those links. And then what we will be doing is the minute we get that information through in a useful source, we'll be sharing it far and wide. We'll be singing from the hilltops, the hills are alive, the sound of music, and PCARP and Pharmacy First, and we will be absolutely getting that information out there, and it will be really evident where there are areas of excellence and areas of potential opportunity. Let's put it that way. Cup half full, not cup half empty. There will be potential areas of opportunity that we will be able to look at and support and put those interventions in place to make sure that we've got those links between GP practice and pharmacies, and patients are then getting the access and the service that they deserve.
Well, thanks, Pam. Stephen?
Yeah, just from a regional perspective, I mean, obviously, I echo everything that Pam and Louise has said, particularly that local level engagement is really crucial and important between pharmacy and GP practice. But from a regional perspective, this time, I'm not aware of any plans to actively incentivise GP practices to refer to pharmacy for this service. However, what we have done at regional level, and I know my other regional counterparts have done similar, is we pulled together a support toolkit for GP practice, which has helped supplement and complemented in what LPC engagement colleagues have also done, to highlight how the service works and the key crucial element of why they should refer. So as we said before, when they refer, they are actually passing on that clinical responsibility from the GP practice to the accepting pharmacy. It's a warm patient transfer with key information. It opens up then a raft to the youth to deliver all elements of the service. If they don't meet certain criteria for a clinical pathway, they can have then an actual defined referral back into a relevant clinician if necessary, or they can be managed and supported via other methods as required. So we've highlighted the benefits of why they should be referring. We've also got, fortunately, in the NorthWest, so our NHS England regional medical director for primary care, Dr. Paula Cowan, is a massive advocate for wider primary care and particularly community pharmacy services. So she's a massive advocate with her colleagues and counterparts in ICB level to promote the benefits of using pharmacy, referring to community pharmacy, and extolling how skilled and the good quality work that you all deliver. So we have got some key advocates. So we are certainly working on that element. And I think the key element we are trying to achieve as well is making sure and helping GP practices understand the service. So whilst I said before, the importance for yourselves understanding how to manage patients effectively and when you can trick in between pathways and things of that nature to get the best use, it's also a key element of GP practice understanding when to refer, who to refer, and also that you sending someone back through a referral for more clinical input isn't about SPAC. It's not a failed rejection. It's actually a part of the service pathway. So we are doing a lot of that work, and I'm also liaising with national colleagues to help try and promote that wider understanding in the service. And we've done the fanfare, the clinical pathways quite rightly. Let's do that wider back to basics refresh of there are still 3 elements to this service and how can we effectively use it. So all those arms together with all the work colleagues are doing at ICB level and LPC is trying to really promote and maximise the use of GP practice support.
Thanks all. I think the last question that's in the chat is probably more of a statement than a question from Kath at Lancs around making sure that GPs, it echoes a lot of what's been said, making sure GPs need to be clear what they're referring their patients into, making sure they understand what the service pathways are, the medicines involved. Critically, how people come back is one thing I would add to that, to say, how do you have that conversation with the practice around what happens if they need to send the patient back? If there's no other questions, I'll start to wrap it up. However, before you go, just a little bit of a plea. We are planning another series of these webinars. We are planning for future ones of these, just to help and support you deliver patient care and deliver things as the pharmacy contract hopefully expands and we see more and more of these services. We'd really value your input. So if there's any ideas you've got for future events, future webinars, any feedback about tonight, as you click the leave button tonight, there will be a survey that pops up. I think it gets emailed to you as well, but if you can fill it in as it pops up while it's fresh in your mind, what worked, what didn't work, what could have made it better, what else would you want to see? There's a big free text box at the bottom, and we will make sure we review and read all of them. So please feed that in. I just want to again thank all of the presenters for tonight, all of the attendees for giving up their time, and hopefully you've learned something and you've got something of value from tonight. And if you haven't, please let us know why not, or what else you could have got from it, and we'll make sure we learn and get this better. One final comment that's come up in the chat is around it's also about the medicines that can be given for the clinical pathways, as not all GPs understand that. I think that's bang right, Julie. I think that's something that is crucial in that when you're talking around how you're implementing it locally, making sure that GPs understand this. I think the LPC particularly spent a lot of time trying to get to various groups and making sure that GPs, as much as we can, know it, but that cascade is not perfect. It doesn't always get there. So any local conversations you have that support that's even better. But thank you for attending tonight. If there's any elements of it that you feel would be useful to rewatch or to share with your teams, we will be distributing a YouTube link on a recording from tonight. Feel free to send it around. Feel free to get your teams to watch it, because I think the more people we can skill up and learn from the wisdom that's been shared, the better. So thank you, everyone, and I bid you a good night and hopefully a cool night.
Thanks, Adam.
Thanks all.
Thank you.
Thanks, everybody.
Thanks, everybody.
Thank you.